Hi, welcome to the Golden Thread of Counseling and Psychotherapy. This is week 2 of Introduction to Practicum. This is the recording for this week. As we go through this, I just want you to know that I'm giving you kind of the 36,000 foot view of what counseling looks like. Of course, we're not going to get into theoretical models, into the details of counseling, that which you will learn to do over your full professional development. But the golden thread of psychotherapy is really to emphasize or punctuate that therapy should have this sense of continuity from the time that the client walks into the counseling room for the first time all the way through the last progress note that we make with them. There's 4 steps that we're going to talk about throughout the counseling process. It all begins with assessment. We gather data. You may be using screening tools, assessment tools. You may gather information from family members using collateral information to help make the assessment of what is going on with that individual. And of course, the more that's going on, the more trauma that one has experienced, the more difficult assessment can be, because an individual may have a whole orbit of symptoms and problems that they've been dealing with and trying to manage, oftentimes in maladaptive ways. Perhaps they drink to try to self-medicate, or perhaps they smoke marijuana several times a day to manage to self-medicate. They have maladaptive behaviors that continue to just keep them stuck in this recursive pattern of negative interaction with others. So assessment is where we begin, and we need to understand that we have to be intentional. The more that we learn and more we understand about humans and the human condition, the better job we can do at assessing. The second phase is diagnosis. We take all the data that we have gleaned from our assessment process, and we go to our DSM and we look at what's going on symptomatically, how long it's been going on, the severity of the effects of what's going on in that individual's life, and we use our clinical judgment with our skills, our experience. Oftentimes, particularly in the beginning as a practicum student, you will be consulting with your supervisor as you're looking at making a diagnosis that is the most accurate, because the most accurate diagnosis leads to the most successful treatment planning. And treatment planning is the third step, and that is when we work with the client, we have a good understanding of what they've been experiencing, how it's affecting their life, what domains of life that is impacting them. We discuss with them how we came to the diagnosis that we came to, the implications of the diagnosis. Not that the diagnosis is, a death nail for them, but that it's just the reality of what they've been experiencing. And we may have them work with a psychiatrist who can prescribe medication, and medication often is very necessary. It can be very, very helpful in helping to treat different mental illnesses. But medication is not always necessary or warranted. But we take care to explain the diagnosis to the client so that they are informed, that they're educated. And with that education of the diagnosis, the client can participate with us in treatment planning. Does it need medication? Do we not need medication? Do we need support from different people in the life? Do we need to have less support from some people in their lives? Do we need weekly therapy? Do we need more intensive therapy in the beginning? So treatment planning is the result of the diagnosis. And when the client really understands the diagnosis and how treatment can help improve their lives, reduce the symptoms of the disorder that they're experiencing, they'll be more invested in the treatment planning and the ongoing treatment. They'll be a more faithful client. They'll show up for sessions more often when they feel and they experience that treatment is making a difference for them. Then once we've developed the treatment plan with the client, we do session notes or DSM progress notes. And those progress notes tell the story of treatment. There's a continuity, the golden thread that weaves throughout the treatment notes, and it holds everything together. Every treatment note points back to the treatment plan that you created and how you're moving toward the goals, the objectives in that treatment plan. So that's a 36,000-foot view of the golden thread, what we need to be doing, what we're mandated to be doing in treatment with our clients. Now, our course objectives for today are going to be different than when I teach this as a 3-hour course. I want you to really understand that we do have an ethical and a professional mandate to provide good records for our clients. The records belong to the client. They're not ours. And when we understand the need, the requirement for this golden thread throughout our records, we're delivering better care to our clients. We're delivering protection for our clients. And we're delivering protection for ourselves, because the care that we're providing, should that care ever come under question by an insurance company, by the licensure board, by a court of justice, then it's this record, this clinical record you have for that individual that is your defense. Some of the slides I'm not going to speak through. I'll just leave them up on the screen to let you view. Some I'll move through more quickly. I'm not going to comment on every slide because for the purposes of week 2 and intro to practicum, they're just not necessary for me to comment on, and or they are for individuals who have more experience. They're in private practice, or they're working in an agency, and in a couple of years you'll be ready to receive that information, and because you'll know what to do with it. But for the purposes of this course, we're just not going to hit on every item. So when you think about, you've been in some courses now, you've had at least 9 hours of academic coursework here in the program to be taken intro to practicum. Don't know what courses you've taken, but from just your experience, you're sitting through classes, you're hearing people, other students talk. about diagnosing and documenting. I don't know if you've considered how central diagnosis and documenting is to the work that you do. Sometimes for some folks, it's the most arduous part of what they do as a therapist is maintaining the paperwork, keeping up with the paperwork. For those who perhaps have gone through a program that didn't emphasize assessment and diagnosis and documenting, they're having to learn that after they go out into the workforce. In this program, we want you to be competent. We want you to have a strong sense of competency when it comes to assessing, diagnosing, and providing treatment plans, developing treatment plans, and documenting your work. I'm going to leave this on the screen, just hopefully you can read it, but I'll read it in case you can't. The golden thread is a consistent presentation of relevant clinical information throughout all documentation for a client. The golden thread begins with an intake assessment that clearly identifies an appropriate clinical problem and the corresponding diagnosis. Next, the treatment plan should reflect clear series of goals for helping the client through the identified problem. Each goal should have specific interventions prescribed that reflect best practices and evidence-based treatments to help guide the client along the path to recovery. Finally, the golden thread includes progress notes that demonstrate that services you deliver match what was prescribed in the treatment plan. Each note should lead into the next, creating a comprehensive story of the client's progress through treatment. Here's a visual of the golden thread. On the far left, we start with intake assessment. We listen to the presenting problems that they're experiencing. We use our DSM to do a good job of differentiating between maybe several possible diagnoses. Then we provide our diagnostic justification. And that leads us into the treatment plan. And the treatment plan, again, is collaborative between you and the client, what they feel their needs are. You help them devise objectives, stepping stones to reach their goals. So now you have your treatment goals, and each session works off of those treatment goals, those prescribed interventions that you bring to the table. You have sets of competencies that you know may be helpful for this client, help this client reach their treatment goal. So we want to ensure that whatever process you're providing is always pulling relevant information from one note to the next. I'm going to move through these documents because we no longer use those in the program, as now we use an electronic health record system that you'll become acquainted with pretty soon. So what guides our work? Rules, regulations, and codes of ethics. Those are bumpers in the road for us. It provides us guidance on the work that we do. As long as we stay within those bumpers in the road, then we are not causing harm and we're working ethically with our clients. So I'm going to share some codes of ethics from different professional associations. They're not what guide our profession necessarily, but I want you to see the likeness in codes of ethics around this whole issue of documenting, assessing, developing treatment plans. So art therapists are to develop and use assessment methods to better understand and serve the needs of their clients. That means that the art therapist has to be familiar with the reliability and the validity and the standardization and the error of measurement and proper application of assessment methods that are used. As marriage and family therapists, we don't in our master's program, we don't teach psychometrics. We don't teach you to do psychometric testing. We will introduce you to different screening tools and assessment tools that you can learn to use and have a competency in using. During the initial phase, art therapists and clients develop treatment plans, goals, and objectives to assist the clients in attaining maintenance of the maximum level of functioning and quality of life. So we as well, we develop treatment plans, and in those treatment plans are identified the goals and objectives to help the client move to a higher quality of life that they can maintain. Informed consent is an ongoing part of the counseling process. We are required to have purposeful and intentional conversations with our patients about the counseling process. We have to have their informed consent. They need to understand confidentiality and the limits of confidentiality. We'll talk more about what you have to communicate to the client in that first session. But I believe that this informed consent is an ongoing conversation. It's not a one and done. Counselors explicitly explain to clients the nature of all services provided. What are the purposes, the goals, the techniques, procedures, limitations, potential risks, potential benefits? What are your qualifications as a counselor and any relevant experience that you may have? In the beginning, as a practicum 1 student, you'll be doing co-therapy with a practicum 3 or more experienced clinician. You'll explain, I'm Tony Watkins, I'm a student in the Master's of Marriage and Family Therapy program here at Campbellsville, and as a practicum 1 student, I do co-therapy with my lead therapist, Dr. Ken Hollis, and our sessions are recorded for quality assurance and for training purposes. We ensure that the information, the recorded information, just as your clinical records are secure. We protect the privacy of these recordings. I may not use this recording in supervision and for training purposes, but I want you to know that after I use this recording, it will be erased and is password protected so that others aren't able to access it. I'm the only one who can access this recording. We work jointly in devising an integrated individual counseling plan that will offer reasonable promise of success and that are consistent with the abilities, the ethnic, social, cultural, and values background and circumstances of the client. We regularly review counseling plans to ensure their continued viability and effectiveness, respecting the client's autonomy. A standard of practice is that you review your treatment plan every 3 months. Now, if you're working with a client and it's evidence that progress is not being made, maybe we need to stop and review the treatment plan before that 3 months. But again, you can get consultation from your supervisor around those issues. We are to utilize educational and psychological and diagnostic tools, interviews, other assessment techniques. You want to use reliable assessment tools. We introduce you to the DSM-5 cross-cutting 1 and other cross-cutting 2 tools and measures. Those are reliable. We use assessments only in the context of professional, academic, and training relationships. That means you don't go home and use the tools and assessments on your kids or your spouses. We provide the client appropriate information regarding the reason for the assessment and the approximate length of time required, and to whom the report may be distributed. Now, for our purposes, here's what counseling will look like. The first session is just for you to develop a relationship. We call that the joining session. We're gathering data, we're listening to the story, we're gathering information about what's going on, the history of what's been going on. But it's really important that we stay attuned. In this session, I'm not taking many notes. I may have a notepad in my hand and I'm just putting down some keywords. But it's really important that that client feels like I'm really present with them. I'm making lots of eye contact, not to be uncomfortable with that client, but they need to know I'm there, I'm listening, I'm present. The second session is more intentional about you've been listening to the first story, you've been hearing what's going on, you've developed a hypothesis of what may be going on, and now you want to do some assessment. So you'll use the DSM cross-cutting measure. And as you assess that cross-cutting 1 tool, that will guide you to what do you need to assess at a deeper level. Perhaps that cross-cutting 1 measure informs you that this person is probably suffering from moderate depression. Well, you want to use the depression level 2 tool to get a deeper look at that. We always respect the rights and the dignity of clients in assessment and interpreting those assessments and in the diagnosing of their mental illness. And we make every effort to assure that the client receives appropriate treatment. So based on the diagnosis and other assessment summaries on multiple sources of data, wherever possible, again, we want to get as much information from as many sources as we can. So we ask family members. We may, if they've seen a therapist in the past, we may request those records. So the more data you have, the more the conclusive your assessment and your diagnosis will be. If you're tasked with writing a report, you want to make sure it's written in a clear, concise, and easily understandable way so that the reader, they're not trying to read through the lines and figure out what's being said. So this is from the National Board of Certified Counselors. NCCs shall recognize results that are outside the norm of a given test or assessment. And again, you're not going to learn psychometric testing. So this point is not really pertinent for our purposes and our program. It's important to always keep accurate records of payers or what the funding source is. So in your EHR, you'll always enter, their payment amount. You know, I share this slide to just lift up the fact that every part of the chart, the patient's chart, is important and purposeful. Now, when we talk about risk management in our field, we're talking about risk management to protect the client and risk management to protect you, the therapist. Record keeping ensures that we are practicing ethically, and when we can evidence that we're practicing ethically, that is protecting our practice. So the big picture, again, kind of a quick review. Good records are the primary proof of quality of care. There's no other way that you can evidence that you are delivering good care. You could be the best therapist in the world, but if you don't have documentation to support that, you have no evidence. Keeping psychotherapy records is a part of the standard of care today. I hear that there are still clinicians who don't believe that they have to keep client records, and that's unfortunate, I believe, from the field, because that truly is a standard of care now. So you may have heard that, as marriage and family therapists, we don't diagnose because we don't want to pathologize anybody. Today we do diagnose. There may have been a time when before we were licensed individuals and insurance was paying for our services, that the field was had a different perspective than the other mental health disciplines. But I want to assure you that today we do diagnose. We're required to diagnose. We have a professional, legal, and ethical responsibility to know how to diagnose. But we also have a responsibility to not pathologize that individual. Part of that not pathologizing an individual is to use person-first language. Perhaps you've heard people say, "Oh, I've got this bipolar," or "I've got this personality disorder." People are not ever to be identified by their diagnosis. They are people first. I'm Tony Watkins. I'm not Tony with a bipolar disorder. And so it's very important that as you enter this field, this profession, that be sensitive. You may hear others, call them out on it. Say, "Oh, so Tony is a bipolar disorder," and just not in an ugly way, but just in a kind, gentle way. You just say, how about we all commit to one another that we're going to use person-first language. Because a person may have bipolar disorder, but with good treatment, good therapy, they can manage that disorder just like anyone with diabetes can manage their diabetes and live full, healthy lives. We must assume that no records are immune from disclosure. What do I mean by that? Yes, there's confidentiality in our field to protect client records, but there are many circumstances that records could be subpoenaed. Law enforcement could require us to disclose records. We'll get more into that, but I just want you to know that we can't assume that a set of records are completely immune from disclosure. You never want to alter the records. You can do addendums, but you never alter the original record. And you always follow state, federal, and professional organizations and HIPAA guidelines for record keeping. Not keeping records truly is below the standard of care. It's unethical, and in many states it's illegal. So we keep records because if it wasn't recorded, documented, it never happened. And if you're the treating therapist and you become incapacitated or you die, you owe it to your client to have kept good records so that the next therapist that individual starts to work with can go back and read the story of treatment. Look at the progress that the client has made. Understand the treatment plan, what the goals were, how you came to your diagnosis. To be able to read the assessment information that you gleaned from that client when you were working with him or her. Now, I'm going to share with you several basic guidelines, and these are aspirational guidelines. It's something we aspire to achieve. They're not, all of them are not going to be black and white. You have to do this. And in general, they apply to many situations, clients, and settings, but not all client settings and situations. So if you're keeping a hard copy of records, for years and years, we kept paper charts. On one side of the file would be demographic information, the treatment plan, all of that information. And over on this side, we would have the treatment notes, the progress notes. And then in another file, sometimes within the same file in a different section, the medical records would be kept, or the billing records. Today, all of this is found in one place in your electronic health record system. I really appreciate electronic health records now because in August of 2019, I was in Austin, Texas, presenting at the AAMFT conference, and my office burned. The building in my office was burned, and I lost everything. But I did not lose my records because they were no longer paper records. They were electronic records stored in the cloud. And I can't tell you what a relief that was, that I didn't lose my records. You always have to protect your computer records. You do that by having at least 2 passwords to get into your computer. You know, when you open the lid of your computer and you turn it on, you should have to enter your password. That's one lock and key. Second lock and key to your electronic health record, Theranest is the platform we use, is when you have to enter your password to get into Theranest. Never allow your computer to save those passwords. You're taking away one of the keys to a lock. And the standard in the field, and you will be held responsible for this, is that your access to your clinical records are under double lock and key. Let me give you an example of how easy it could be to violate that. Let's say you're in counseling room 1. You have a client from 10 to 11, and then no clients are booked in that room from 11 to 12, and then you're back in there at 12 o'clock. So you just leave your computer in there, your stuff in there, and you're working in your electronic health record, and you stand up to go get a drink of water or use the restroom. you left your computer on and it's open to your electronic health records, Theranest. Somebody could walk in and see that. That's a violation. So when you walk away, you need to log out, save your work, log out. What's it take? 10 seconds to log back in? Those are kind of things, quite honestly, I'm going to be looking for in the clinic. I'm going to be looking for, not to get you, but to teach. Because, I don't know about you, but when I really make a mistake, I only have to make it once. And I learn from that mistake. So make sure that you don't take your computer being on, left open for granted. And then we want to make sure that we enter clinically relevant and meaningful information in the clinical records. What does that mean? I'm not going to talk about how Betty went to the mall and hung out with her kids for the day. That's not relevant or meaningful information. But when Betty went to the mall and she was getting in the elevator to go upstairs, and a man got on the elevator with her and the door closed, and she was in that elevator by herself with this man. She panicked. Fear came over her, and she was frozen. That is relevant, meaningful information. Want to make sure that records include basic demographic information, mental status exam, diagnosis, or presenting problems. It doesn't have to be a DSM diagnosis. It could be a familial diagnosis, a developmental diagnosis. But in this program, it will always be a DSM diagnosis. It has to include the fee agreement and the treatment plan. If relevant, we need to include risk factors, medical and other issues that are relevant to the treatment, and collateral information and request for information. An ROI, request for information, is a document that if you want to request notes from the previous therapist, you have to have this client sign a release for information, and then you mail that to that clinician, and then they have 30 days once they receive it to respond, get you those notes back. First session before treatment begins, you go over office policies and informed consent with the client. That includes limits of confidentiality, what the fees are. We don't do third-party billing here. You go over the client rights, cancellation parties, etc. So office policies, informed consent. I believe Dr. Hollis has sent a copy of all the in-office paperwork that we utilize. So you have that in an email from him. If you don't, let me know. I'll email it to you. Be familiar with that paperwork before you see your first client. Update your treatment plans. Report on your progress or lack thereof as necessary. Every session, there's a portion of your electronic health record that where you identify progress. Reports should reflect your competence, your thoughtfulness, decision-making ability, capacity to weigh available options. I am choosing to focus on Betty's panic attacks when she feels that she may be under threat by a male in close proximity. There may be 10 things that Betty talks about that are upsetting for her. And that's where your clinical skill, and in the beginning with your supervisor, you're using clinical judgment to say, okay, all of these things are going on with Betty. But I believe from her story, from my assessment, that at the core of all these things is this one issue. And so we want to really zero in on that one issue. And we believe that by treating that one issue, these other symptomatic concerns are going to decrease in severity as well. We never clone records. That means we don't copy from one progress note and paste it into another. You never use one client's notes and post them into another client's notes. Sometimes, let me go back. If you're using a checklist and in the EHR, often it'll, around an issue, let's say a person's affect, their mood, there'll be a drop-down box and it'll give you several options you can choose from. Just click on that option and that'll populate into the field for you. SOAP notes are perhaps the most recognizable type of note to use. The acronym stands for Subjective, Objective, Assessment, and Plan. The subjective is the client's words. You'll use verbatims in the subjective. Client reports that when she was at the mall over the weekend with her kids, she got on an elevator and was by herself, and at the last minute a man stepped on and she froze. She became very fearful. So you're telling her story that she's told you. Then the objective is, how does this make sense to you clinically, diagnostically? How does what she is bringing into the therapy room that day, how does that connect with what's going on with her emotionally? Then assessment. Due to the setback that Betty has felt in the days following her trip to the mall and her being, you may put in quotes, feeling paralyzed when the man got on the elevator with her. Betty has not been able to go to work, and she has taken a turn from the improvement that we were seeing that she was making around these intrusive thoughts of the rape that she experienced 6 months ago. Today, she is not managing the fear, the trauma, as well as she was prior to the event at the mall. And then what's the plan? You develop a plan. So Betty, do you think you're going to be able to go back to work this week? Yeah? You think you can go back Thursday? Okay. So can we just plan on that? Then you talk about that. What happens? How will you know you're ready to go back to work on Thursday? What might be something that would keep you from going back to work? So you process all of this with her. Get her prepared. Because without a good plan, progress isn't going to be made. I'm not going to talk about the DAP, but that's another type of note that is utilized. We want to appropriately document special occurrences, things like important phone calls. Perhaps Betty calls you from the mall and says, I'm just, I don't know what's going on with me. I just feel paralyzed, and I'm with my kids and I can't even drive home. You want to document that. You want to document if there's an emergency that comes up with the person, or if they have to be hospitalized. If there's a mandated report that you have to make. You may be working with a family and it's disclosed to you that the mother abused the 6-year-old little girl physically, and you have to report that. You want to document that. any tests that may be run. We don't talk a lot about this in our field, but oftentimes I will, as I'm beginning to work with somebody, I'll have them go to their primary care physician and have blood tests run. We always have to rule out physiological possibilities that may be the underlying reason for this person having what look like mental illness problems. So we want that to be ruled out. If you have contact with family members or if you're making referrals, all of that information needs to be documented. Make sure that your records include the following forms. We've talked about this. I can assure you that here at the clinic that they're going to. When you terminate with a client, whether it's they just quit showing up, if they just quit showing up, then you will communicate with them by letter. Have a copy of that record or that letter in the record. You want to note how you tried to follow up with them and so forth. We can't just let people fall off the face of the earth. So we have to maintain records in Kentucky for 6 years. So from the last date of a client's service, we keep records for 6 years. If we're working with somebody who's a minor, we have to keep the records till the age of majority, which is age 18, plus 3 years, I believe, here in Kentucky. Again, all of our records are cloud-based, so we keep our records. We'll keep our records forever. Do not include any clinically superfluous details that can cause unnecessary harm for clients and others. An example of that may be, client reported that a man in her office flirted with her, and it was upsetting to her that he flirted with her. That might be relevant, that may not be relevant. Again, you'll have to use clinical judgment. Your supervisor will have access to your clinical records. They can review those. That'll be part of supervision. Your supervisor has a responsibility to ensure that you're documenting appropriately so that they can help you understand if superfluous details are being put into the record or not. Document as applicable. Give the clinical rationale, and when appropriate, include your ethical considerations for, if a client brings you a gift, if a client brings me just a little token that's not over $25 in cost, I can take that, I can, put it out on display. I've had clients over the years bring me little gifts of appreciation, and I have them in my office and as kind of reminders of those clients and their appreciation for the work we did. Document if there's extensive use or of touch or self-disclosure. Sometimes we think that disclosing something about ourselves may be helpful to a client, and we always have to be careful with self-disclosure. But if you disclose something personal about yourself, you need to document what you disclosed and why you disclosed it. Perhaps at the end of a session, a client says, I want to thank you for all your help, and they embrace you, and that if that embrace is long or feels uncomfortable, you'll want to document that. If there's a dual relationship, you want to document the nature, the extent, etc. of that dual relationship. When I lived up in Owen County, I just had to learn to manage my dual relationships. I was the only clinician in town. So if my barber, for example, if my barber wanted to enter into therapy, I would have the discussion with my barber that, I want you to realize that this relationship could feel uncomfortable to you. I want you to think about when I come in to get my hair cut. Are you cutting my hair thinking about, I wonder what Tony thinks about me because now that I've told him all this personal stuff about me. So you want to manage those dual relationships, and if you need help with that, talk to your supervisor about it. Out of office experiences, I'll give you a humorous one. My wife and I were at the Smith House restaurant in Owenton after church one Sunday, and a client that I'd been working with walked into the restaurant and came over to my table, and in front of the whole restaurant, very loud, she said, "Well, you must be Tony's wife." She said, "I'm so glad to meet you. You got such a wonderful husband. I know he's told you about me because I'm just crazy." And I patted her on the arm. I said, "It's good to see you, and go enjoy your meal." But I was embarrassed for her. My wife was embarrassed. I guess it's called secondhand embarrassment, maybe. I don't know. But I documented that because that was an out-of-office experience. Now, as a rule, I tell all my clients that if I see you out in public, I'm not going to wave. I'm not going to come up to you. I'm not going to even acknowledge you because I want to protect your anonymity. But if you wave to me or if you come up to me, I'm going to reciprocate. In Alabama, where I live, small community, I see a lot of people from my church. The pastors in my community refer a lot of people in their congregation that need more help than they're able to provide pastorally. But people in my own church, they understand that if I see them, I'm not going to talk to them. I'm not being snobbish. And for most of them, that's what they prefer. They don't want to be having fellowship with their therapist as a rule. Again, we store all of our information under double lock and key. If it's physical, a physical chart, then it's stored locked in a filing cabinet, for example, and the door is locked. That's double lock and key. Now, with all the new advancements in digital interpersonal communications, cell phones in particular, the use of text messaging and online recording services has many ramifications regarding security, privacy, and confidentiality that aren't real clear yet. So we have to use caution and informed consent when using digital methods to communicate, primarily text messaging and emails. In our EHR, there's secure text messaging that you will have to use to communicate with your clients. You're not going to do it on your cell phone. That's just a standard that we have in the office, in the center. Therapists will review with clients the circumstances where confidential information may be requested and where disclosure, confidential information may be legally required. We're not going to go into the weeds there, but that this is the type of things you'll learn as you develop professionally. PHI is protected health information. It has to be safeguarded according to the privacy rule. If you're using electronics, computers and such, there's also other acts that other rules that we have to follow. So what are individual identifiers? Things like a person's name, their date of birth, social security number, their address. These are individual identifiers. So a healthcare provider may disclose or use a patient's medical information or progress notes when the privacy rule permits that to happen. when the patient authorizes or the use or disclosure through signing a release of information. When the individual requests their information, guess what? We have to provide it to them. It's their record. If Health and Human Services, HHS, is conducting an investigation and they request the information, we have to provide it. And if law enforcement requests the information out of public safety, then we have to provide that. Patient or public protection includes the treatment. The following circumstances do not require a patient's authorization for disclosure. So we don't have to have the patient's authorization to treat for their treatment, for the payment of treatment, if we're billing an insurance company or any healthcare operations. If there are public interests and benefits required by law to prevent or control a disease, that's an exception to us having to have their authorization. For government authorities in cases of abuse, neglect, and DV. For health oversight agencies during audits or investigations. For judicial or administrative proceedings. For law enforcement purposes, for funeral directors, medical examiners, and coroners as needed, for research purposes, or when there's a threat to public health or safety, for essential government functions, and in regards to workman comp law. So the security rule mandates under the administrative regulations, this refers to the administrative functions implemented to ensure security, such as security training, which is all taken care of here in the clinic. Physical safeguards, we have to protect the data storage sources. So if the data were stored on a server, it would have to be under double lock and key somewhere here in the building. And then for technical safeguards, if we're using an automated process to protect information and control who has access to that. So, with the EHR, you have access only to your clients. I, as the administrator, I have administrative access, and I have certain rules that I have to follow. I'm going to skip through this because it's taken care of automatically in the center. Some common violations that people experience: unauthorized use of patient information. For example, somebody calls your office or calls you, and they say, "Hey, Tony, I'm Jan Smith's husband. I know you see her on Tuesday nights at 7 o'clock, and I just need to talk to you for a moment about Jan." Well, if Jan hasn't signed a release of information for you to talk to her husband, you can't even confirm that you know who he's talking about. So you'll say something like, "I can neither confirm nor deny that I know who you're talking about, sir. I cannot talk about clients without release of information." So I suggest that if there's somebody that you believe is seeing me as a client, that you have that person talk to me at our next session about me being able to speak with you. Unsecured patient records, again, if you leave your computer open, you walk out of the room, that's unsecured patient records. Patient being unable to have access to the records. Sometimes clinicians, they don't understand that the client has a right to their records, and the law says if a client requests their records in a way that you're able to produce those, then you have to give those to them. You have 30 days to produce them. So if you want to make a copy, you have 30 days to do so, but they do have a right to their records. Not having any administrative or technical safeguards on the electronic personal health information. So we keep counseling records to assist should a client return after a long absence from receiving your services. Say they've been gone for 2 or 3 years and they come back and want to see you again. We keep records to use as a resource should you experience an ethical or legal challenge regarding your work with a client. And we keep records because appropriate record keeping has now emerged as the standard of care. I don't believe I've spoken to this, but there are 2 different kinds of notes that you'll keep. You'll keep psychotherapy notes. Those are your private notes, and you'll keep process or progress notes. So we'll talk about this as we move into this next section, but there are no official guidelines of how you document in a client's chart. Centers for Medicare, and Medicaid say that you have to have the date of service, the diagnosis, the time that you spent in the face-to-face counseling, the type of therapeutic intervention that was provided, what were the symptoms that were targeted in that session, what was the progress toward treatment goals. And for a session that lasts for an hour, you're required to justify why you spent an hour rather than 30 minutes or 45 minutes. Alabama, Georgia, and Tennessee, for Medicare, Medicaid, they have additional requirements. They include documenting the degree of patient interaction with the therapist, the reaction of the patient to the therapy session, and any changes in their behavior or symptoms as a result of the session. Now, there is a difference between psychotherapy notes and progress notes. Detailed notes help mental health professionals diagnose and treat patients quickly and adequately, and they help patients make informed decisions about themselves. Healthcare professionals are required to properly document medical information. In the mental health field, counselors, psychologists, and other professionals rely on insightful and thorough progress notes and psychotherapy notes to devise treatment plans. So the difference between the psychotherapy note and progress note, psychotherapy note is where you will write down what your observations, may be, hypothesis that you have about what's going on, questions that you want to ask your supervisors, any thoughts or feelings you have related to the therapy session. Psychotherapy notes are private. These are for your eyes only, and the client never gets to see them. They're not, if the insurance company requests notes, they never see your psychotherapy notes. Progress notes, on the other hand, are about the treatment itself. They're psychotherapy notes, again, those private notes have to be kept in a separate section of the medical record. You are not permitted to share psychotherapy notes without the patient's authorization, and a patient does not have a right to access those notes. So why do we keep them? Well, we keep them because they may be information that we just don't want, we're just using them for ourselves. They have nothing to do with, the immediate treatment and care of the client. The older I get and the more concerned I become about my memory, the more psychotherapy notes I keep. Psychotherapy notes, like I said, might include observation, hypotheses, questions to ask supervisors, thoughts and feelings you have about the session. They do not include medication details or records. They do not include test results. They do not include summary of diagnosis or treatment plan. They do not include summary of symptoms and prognosis or summary of progress. There is a catch in the psychotherapy note provision. HIPAA defines psychotherapy notes as those notes that are kept separate from the rest of the individual's record. So it's very important that they are in a separate place. They're not intermingled with the progress notes or the other parts of the chart. Providers can use notes, and notes may be required to disclose and may be required to disclose notes. To use the notes for treatment, I've discussed this earlier, so I won't reiterate this point. Psychotherapy notes are not required for insurance purposes. Just remember that sometime down the road when you are billing insurance and they request records, you do not include your psychotherapy notes. Progress notes are meant to be shared with other healthcare workers who assist with the patient's treatment plan. It's always best with progress notes to follow a template, make it easy to access, make them clearly written, make them consistent in style to help minimize mistakes or misunderstandings. And progress notes are essential documents in regards to billing and reimbursement. We talked about SOAP notes and DAP notes. Here's a link for your information to what the minimal necessary requirements that have to be in a SOAP note. So that's all we have for this time together. I hope this has been helpful. Hope this kind of helped flesh out, answer some things. And you can always come back and access it again later. Hope you have a good rest of the day.